So I'd now like to extend a very warm welcome to Associate Professor Alex Hunyor. Alex, as most of you will know, is a Sydney-based retinal specialist and expert in vitreoretinal surgery and macular disease, and is also the chairman of the Macular Disease Foundation Australia Medical Committee, as well as an MDFA board member. A clinical associate professor and member of the Macular Research Group at the SaveSight Institute, University of Sydney, Alex is involved in numerous clinical trials for treatment of retinal disease. Alex serves on the RANSCO Medicare Advisory Committee and is involved in teaching optometrists, ophthalmic trainees and local and international ophthalmologists, and has received the RANSCO Award for Excellence in Training on 4 occasions. Welcome, Dr. Hunyor.
Thanks very much, Sabine. It's a pleasure to be here. As you mentioned, please everybody feel free to ask questions through the Q&A. I'll just quickly share my screen. Okay, so just checking there. Has everybody got the presentation there? Sabine, are you seeing that okay?
Yep, perfect.
Terrific. All right, so as Sabine said, we're going to go through the classification of AMD and some info about the AREDS studies and supplements and a few other things, and answer most of the questions that you've sent along the way. So I think as far as classification of AMD is concerned, I think that, you know, on the one hand, you can sort of say, oh, well, look, we all know what AMD looks like. We don't really necessarily need to get too tied up in it, do we? But I think that there's a few misconceptions that we should deal with, and also highlight the value of actually having a unified sort of classification of AMD. One of the problems, and it's a lot of it's to do with the colloquial language that we use to convey things to patients, is the whole wet and dry thing. So optometrists, ophthalmologists and retinal specialists over the years have just said, oh, well, we know what wet looks like, so if it's not that, then it must be dry, which is a pretty simplistic way to look at it. And really, you know, although these are very well entrenched colloquial terms, we're eye care professionals, and we can do a bit better than basically categorizing this into neovascular and sort of everything else, because there are obviously very distinct stages, and we've got a lot of technology at our disposal now. So why should we care about the classification? I suppose, first of all, it allows us to speak a common professional language so that we all understand what we're talking about when you describe, you know, whether it's early or intermediate or advanced AMD. It very much allows better prognostication for individual patients, and I'll show some of that in a minute. And also, increasingly importantly, and several of your questions were with regard to new treatments. We need to have very accurate descriptions of stages of AMD to determine if people are eligible for clinical trials. At the moment, there's a lot of activity in trials for geographic atrophy, but there's also going to be other interventions for early and intermediate AMD. I'm not sure about actually preventing or curing AMD, but obviously we'd like to catch it at an earlier level. So when we're assessing AMD changes, the two things that we're looking at are Drusen and AMD pigment changes, as shown in the picture there. And the larger studies like AREDS, the changes we're talking about are within 2 disc diameters of the center of the fovea. And AMD pigment changes are defined as definite hypo or hyper pigmentation in association with Drusen, and not due to some other condition that the pigment changes can be attributed to. So as I said, it's within the 2 disc diameters of the center of the fovea. So when you look at mid-peripheral and peripheral Drusen like these, that's not AMD. So in terms of documenting the size of Drusen, the reference, I mean, certainly you can measure it out on photographs, but as a clinical and photographic guide, if we use the width of a major branch vein as it crosses the disc margin, that's roughly accepted as being 125 microns. So as a result of that, that's used as a bit of a yardstick for Drusen size estimation. And it's the smallest diameter. So for example, if you've got a druse like this, the diameter that you're using is across, well, technically diameter is not the correct term, but that's the dimension that you're using to determine the size of the druse. And obviously, OCT is a much more sophisticated way to measure these things, but the clinical assessment and measurement is done on the basis of either clinical examination or fundus photography. It's not done on the basis of OCT. So small drusen, and I apologise, they're usually a bit tricky to see in photographs, are less than 63 microns. So using the magic 125, that's half of that, give or take. So it's less than half of the width of that reference vein. Medium-sized drusen are between that size, but less than 125, which is the full width of the vein. And then large drusen are 125 microns or greater. So moving on to the AREDS study, the original one, or now referred to as AREDS 1, this was a rather busy looking table with the eligibility categories, which I won't go through in great detail. Essentially, the background of the study was that there was widespread use of antioxidants and zinc for AMD, despite the fact that there wasn't really good quality evidence. And so the National Eye Institute in the States decided to do a very large study. They'd actually been talking about doing a study like this since about 1986. And they enrolled almost 5,000 patients between 1992 and 98, and they were followed to 2001. And they were randomized to either antioxidants alone, zinc alone, antioxidants plus zinc, or placebo. They were also allowed to take a multivitamin if they wanted to, which 67% of them did. And the so-called AREDS formula, the original AREDS formula, was the third one listed up there, which was the combination of the antioxidants plus the zinc. And the copper is in there so that you don't become copper deficient, because zinc competes with copper absorption. So the bottom line, without going through excruciating detail, is that if you look at eligibility categories 1 and 2, so they've either got no drusen or small ones, less than 63 microns, which are also called druplets, or you've only got small or intermediate without pigment abnormalities, then and you can't. You may have pigment abnormalities, but you can't have geographic atrophy. Essentially, so this is not AMD because small drusen on their own are just normal aging changes. So essentially, that's no AMD, and that's early AMD, and supplementation, regardless of which kind, had no effect. And then in the second cluster here, so groups 3 and 4, so either intermediate AMD in one or both eyes or advanced AMD in one eye only, so obviously you can't have it in two eyes, then there was some risk reduction in terms of the progression of macular degeneration to late stage AMD. So you can see from looking at the graph here in terms of what they call the probability of an AMD event, which is progression to late AMD, that it's not surprising that you couldn't demonstrate any benefit in categories 1 or 2, because the probability of them having this sort of event in the first place was incredibly low. But if you look at groups 3 and 4, they've actually got quite high probabilities of these things occurring over the 5-year period between year 2 and year 7. So the bottom line for the AREDS 1 study is that for groups 3 and 4, the placebo group had a 34% chance of progressing to advanced AMD, and the antioxidant and zinc group, so that the AREDS supplement, so-called, reduced that to 24%. So that's a 25% risk reduction. So it is a pretty modest effect. So in practical terms, with the patient sitting in front of you, it's either the patient with intermediate AMD in one or both eyes, so that's large drusen or numerous medium drusen, or group 4 where they've got advanced AMD in one eye. So it's not without issues, the AREDS study, and there's been controversy about it since the results were first published. The issue of lung cancer in smokers. There were two large studies that were done, which overlap with AREDS 1, in which they demonstrated that people who took beta-carotene and also smoked had an increased risk of lung cancer over and above what they normally would have as smokers. And then there are various aspects of the statistical analysis of the study which have been questioned by some people. In terms of visual loss, so there were two primary outcome measures, one of which was related to the progression of AMD, which is what I've just mentioned there, and the other one was related to visual loss, so that's loss of greater than or equal to 15 letters from baseline, so three lines on an ETDRS chart. So you can see that the odds ratio with a 99% confidence interval, the confidence interval just avoids crossing 1 if you look at the unadjusted antioxidants and zinc versus placebo, whereas with it being adjusted, then it actually fails to reach significance. So AREDS 2 came about because there were additional questions about a few things. First of all, beta-carotene didn't seem to be the best idea in terms of a carotenoid supplement, and lutein and zeaxanthin were now available in a bioavailable form, and so the question was whether or not adding those or omega-3 fatty acids, which were also very popular. So essentially varieties of fish oil and other things which contain a lot of DHA and EPA. So could those further reduce the reduction in risk of AMD progression? Would removing the beta carotene and or lowering the zinc doses make any difference to the risk of AMD progression? They were the two main questions. And so all of the patients either took the original AREDS formulation or a modified one which had no beta carotene or reduced zinc or both. And then they were also randomized, so there was a second randomization to either lutein, zeaxanthin, the omega-3 fatty acids, or both, or placebo. So this study, AREDS 2, only included the patients from groups 3 and 4 of AREDS 1, as you would expect, because groups 1 and 2 were not shown to have any statistical benefit. So the bottom line there, adding lutein and zeaxanthin and or omega-3 did not make any difference. Removing beta carotene and or lowering the zinc dose also made no difference. And keeping beta carotene, not surprisingly, led to more lung cancers, and they were mostly in former smokers. So don't add omega-3s because they didn't give any additional benefit. And even though lutein and zeaxanthin didn't give an additional benefit on top of beta carotene, it made sense to just replace beta carotene with lutein and zeaxanthin because there's basically no downside and it removes that risk of increasing lung cancer. So what we've ended up there is the AREDS 2 formula, which is essentially very similar to the AREDS 1 formula, except the beta carotene is out and it's replaced by lutein and zeaxanthin. So this is the first question from registration, and that's just a simple question about when to use AREDS 2 versus AREDS. And really, I just think it's simpler to use AREDS 2. There's no downside to doing that. And in practical terms, the supplements in Australia, with the exception of one that's no longer on the market, have never actually contained beta carotene because the risk of lung cancer was known, and that was even in ex-smokers, not only in current smokers. So the bigger question really here, and someone else's question from registration leads into this, is are AREDS supplements actually indicated for this particular patient sitting in front of you? In terms of which one of the AREDS 2 supplements, I don't have a personal financial interest in any of the supplement companies, although sometimes I wish that I did. So I don't think it makes any difference as long as they have that as the total per day. Many of the available ones now have it in a single tablet or capsule, but some require taking 2 tablets or capsules a day. Another question here. I attended a lecture that indicated that some AMD genetic subgroups may be harmed by AREDS 2 type supplementation. So that's an excellent question. It's quite a contentious topic. So this is the paper that sort of kicked off the debate, if you like, and it was looking at the CFH, so the complement factor H, and ARNS2, which is age-related maculopathy sensitivity to risk alleles. And essentially the assertion was that there was differential benefit from the AREDS type supplementation depending on people's genetic makeup, and that some people could get more benefit and some people were not only not getting benefit, but were potentially having harmful effects. And this is the one of the several counters, if you like, from the AREDS group. This is report number 18 from AREDS 2, and essentially they straight out say that there is no interaction on progression. So it continues to be a controversial topic, particularly in the States, that of using genetic testing for AMD in routine clinical practice. There's certainly a lot of it done in research studies, but in routine clinical practice, there can be significant problems, particularly, for example, with insurance. If people are demonstrated to have certain genetic abnormalities, not just AMD, but others, they may be excluded from getting insurance, or it may have other implications for them. So other supplements, I won't really waste any time on this. You'll find that people will be constantly coming in telling you about some new thing that they were told about on Facebook, and particularly the companies that have been wrapped over the knuckles by the TGA will have to say a lot of things that may do something, or you know, they contain these things, but that doesn't actually say that they do anything for your eyes. And there's lots of assertions about these things, but essentially they're not proven. So the Beckman classification of AMD, which is really the you know, the ideal that we should all be using, that came out in 2013, and it was a result of the Beckman initiative. They had a large group of very smart retina specialists. I think they had 26 expert drusenologists, and they also had various other scientists and statisticians and so forth. And the idea was to come up with a consensus classification for AMD. So if patients had no drusen, or they only had small drusen, so 63 microns or less, that is normal aging and not macular degeneration. If they had medium drusen and no AMD pigment abnormalities, that's classified as early AMD. If they had one or more large drusen, or they had AMD pigment abnormalities with at least medium drusen, then that's classified as intermediate AMD. And if they had either neovascular AMD or geographic atrophy, that's late AMD. In AREDS, the geographic atrophy needed to involve the center of the fovea, but in the Beckman classification, it's any GA at all. And that's the definition there before of the AMD pigment abnormalities. So one of the really important things about properly classifying AMD is the prognostic significance. So you can see that if patients have got no drusen or small drusen, and they have pigmentary abnormalities, they either don't have any or they've got them only in one eye, then they've got essentially zero chance of progressing to advanced AMD. If they have pigment abnormalities in both eyes, though, they do have some chance. So the pigment abnormalities are driving it more than the drusen there. If they've got intermediate drusen but no large drusen, and they also have pigmentary abnormalities, you can see that the risk is starting to increase. And again, with intermediate drusen in both eyes and no large drusen, the rate's still low, but if you add the pigment abnormalities, then that increases, and all the way through to almost a 50% risk of developing advanced AMD if they've got large drusen in both eyes and pigment abnormality in both eyes. And that's just another graphical representation of it. So you can see if you use the AREDS patient severity scores that it's really getting up to a very high 5-year event rate. So the patients in that high risk group you're looking at being a 10% per year risk, which is pretty substantial. So in terms of those expressions, wet and dry, this is what the Beckman people said. So they said there was a concern that these terms are so imbued in the vernacular that changing them may be difficult, but a step in the right direction would be to limit the term dry to geographic atrophy and not refer to the earlier stages as dry. And so that would provide lay terms for the two types of advanced AMD. So that would be dry for GA and wet for neovascular. And that would eliminate the confusion of dry being associated with the earlier types of AMD. So what I say to patients, and I think that it's it can be useful in terms of being able to emphasize to them that they have one of the milder stages of AMD if they're either early or intermediate, because then they're a little bit reassured that they're not in one of the bad groups, and then just explain that if they develop one of the late stages of AMD, then that's when it's either wet or dry, and then you can explain what the wet and dry are in lay terms as well. So just quickly going through some other things to do with drusen. So you can see here, this image has got a mixture of drusen here, and it's also got some quite pronounced RPE pigment changes. So you've got the medium and large drusen here, the so-called soft drusen. We tend to just use the size now rather than the hard and soft. And then these ones here, which have that slightly more refractile sort of crystalline appearance, these ones, when they regress, you'll go on to develop geographic atrophy in those areas. So that's just the autofluorescence showing the development of those dark areas there where there's geographic atrophy. So in terms of the progression of drusen, and it's quite variable in terms of the speed of progression, but this is just one of my patients. So here in 2012, they're small drusen. There's maybe one medium-sized one there. By 2018, you've got multiple large drusen centrally and some small to medium ones out there, and then even more numerous large drusen and medium drusen a few years later. So drusen disappearing, you sort of think, oh, well, that's good. You want there to be pure drusen around, but the drusen are not really the bad guys. They're a biomarker, and so drusen disappearing is not always a good thing. So you can see this patient's got some drusen, and particularly these crystalline ones here, and 2 years later, that area has progressed to have very significant center involving geographic atrophy, and you can see on the OCT scan there that this is Bruch's membrane, which you don't normally see unless the RPE is either detached or absent. So in this case, it's a large area of bare RPE, which corresponds to this area here. Or this little island here corresponds to that very thin sliver there. So if you want to call something dry AMD, that's dry AMD as far as Beckman's concerned. So this is another case where Drusen disappear over a period of 3 years. And you can see, this is the other eye of that patient that I showed before with a Drusen progression. And what you can see here is that the Drusen in this area have almost all disappeared. And there's a change here, which is a large RPE detachment. So the other thing that can be occurring when Drusen disappear, and we'll go here from 2018 to 2021, is that patients can develop neovascularization or a large pigment epithelial detachment. So once the RPE is detached, then you won't make out the distinct Drusen there. So if you do see a patient who's had disappearance of not just the odd Drus here or there, but a substantial area, then you always need to be suspicious that they might have developed neovascularization or that they might be progressing to atrophy there. So this represents development of CNV, and this patient had a, yeah, there you go. That's what it looked like after a single anti-VEGF injection. So a very good response to treatment. And you can see, you can now appreciate, now that the RPE is reattached to Bruch's, you can actually see the Drusen again there. So reticular pseudodrusen, most optometrists seem to have heard about nowadays. They're also referred to as subretinal drusenoid deposits, and they're an increasingly recognised feature of macular degeneration. So in this case, you can see there's more typical sort of Drusen there, and the RPD, the reticular pseudodrusen, are those less distinct sort of bumpy looking undulations. They're often more peripherally located in the macula, although they can be throughout the macula. And if you look closely at the OCT scan, you can see that these are the Drusen here. So they're located under the RPE, and these are the reticular pseudodrusen, which are sitting on top of the RPE, and they often have that more pointy appearance. So just looking in higher magnification, the Drusen are below the RPE, and this is Bruch's membrane, which is abnormally thick, and the reticular pseudodrusen are above the RPE. They can be relatively difficult to see with standard imaging, so they're often well seen on autofluorescence or on infrared imaging. And they're a risk factor for development of geographic atrophy, but not for development of CNV. So that's a patient with reticular pseudodrusen, so progressing from there with a small area of GA through to that 4 years later. So another question that was submitted by a registrant here: how would you manage patients, quote unquote, prescribed AREDS 2 type supplements for a macular disease that's not AMD? Which is a really good question, and something that you come across all the time in day-to-day practice. And that's sort of one of several issues when you're talking about people who shouldn't be taking them. So first of all, there's patients who self-prescribe AREDS supplements. They may not have AMD, they may be taking the wrong dose, etc. Patients who are in category 1 or 2 who've not been shown to get any benefit. They're sometimes given supplements. If they've got bilateral late-stage AMD, so geographic atrophy or neovascularization, and that can be sort of one in one eye and one in the other. Essentially, you're not going to get any benefit from taking something that's designed to prevent an outcome when you already have the outcome in both eyes. And then there are the patients referred to in the question where they've been recommended to take the AREDS supplements, but they have a macular disease that's not AMD. So, some people say, well, does it really matter? You can't really do any harm by taking the supplements. Vitamin C is excreted in the urine. It's not fat soluble. So essentially, unless you take absolutely mega doses where you can cause renal failure, then that and zinc and copper, you usually won't have run into problems with toxicity unless, as I said, you take massive amounts of any of them. Vitamin E is not quite the same. It's a fat soluble vitamin, so it accumulates in the body. The dose of 400 units daily can potentially, based on other non-eye studies, may potentially have some side effects, although these were not reported in the AREDS study. But I think if you're talking about taking something that is not really going to do you, or it's definitely not going to do you any benefit, then it's better not to. And you've got to also bear in mind that patients are often taking all manner of other supplements, some of which may have vitamin E in them. So onto the question of taking AREDS supplements for things that are not AMD. I can't really ask you the question directly because you're all muted, but essentially, somewhat rhetorically, no, this is not AMD, and there's a few tip-offs here when you look at the combination of the color image and the OCT. So some pretty substantial differences to the cases that I've been showing you. So these lesions don't have the usual shape or distribution of Drusen, and these lesions here shown on the OCT are above the RPE, not below the RPE where Drusen belong. And one test that's particularly valuable for this kind of condition is autofluorescence. And that shows that lovely pattern of hyper autofluorescence associated with pattern dystrophy. So, I mean, nowadays with the combination of OCT and autofluorescence, I do very few fluorescent angiograms, and particularly for dystrophic conditions, arguably autofluorescence is more useful than fluorescein, and people don't really like having invasive tests done when they can have non-invasive tests. So I think that most fundus cameras that optometrists have don't necessarily have autofluorescence. But I think if you're looking to upgrade or get a new machine or whatever, I think it's definitely worth considering that, because it will become an increasingly important imaging modality, particularly in terms of assessing geographic atrophy and patients potentially eligible for studies, and it'll also be helpful for this kind of situation. So this is another case, 55-year-old male. Is this AMD? And at a glance, I suppose you could say, well, these are a little bit odd looking, but these could be Drusen, and there's this sort of variability in the pigmentation. So yeah, it could be. That's the appearance of the OCT scan, which is a bit unusual for AMD. So very severe cystic changes there centrally. And the other thing that really doesn't fit with AMD in this case is the thickness of the choroid. So the choroid is normally is thinner than normal in AMD, particularly as you get to be much older. Whereas this patient has an extremely thick choroid. You can't actually see the choroidoscleral junction there. So if you look at the autofluorescence, again, showing the value of doing AF, you can see this incredibly extensive pattern of abnormal autofluorescence, which really, even with the retrospectoscope going back to that color image, you can't really appreciate the extent of that pigment abnormality. And so you can see these dark areas are where the RPE's sort of dying off. Some of these larger areas are like geographic atrophy and AMD, and all of these surrounding areas of hyper-autofluorescence are where the RPE is sick and metabolically overactive. And this sort of gravitational track sort of pattern is absolutely typical of the chronic variant of central serous. So these are a few other questions that came in today, and they're again they're good questions, and I didn't have time in tonight's talk to go through in great detail things to do with current and upcoming studies for dry, and when I say dry AMD, I mean atrophy. But in terms of current treatment, and I'll, as I said, I'll use that for geographic atrophy. There was a trial, two trials actually, the Derby and Oaks trials, which were reported. The top line results of those were reported literally only a couple of weeks ago, and that's a that involved intravitreal injections of a real mouthful compound called pegcetacoplan, which is a complement 3 inhibitor. And a lot of the trials at the moment are focusing on the complement pathway, inhibiting the various stages of the complement pathway to try to prevent geographic atrophy progression. So they're starting with patients who have some GA and trying to prevent that from progressing to cause visual loss. At the moment, the outcome really is the degree of enlargement of the GA rather than a visual outcome. And that product is made by a company called Palace, and obviously the next hurdles that they need to get through are approval and then funding, etc. But that may be something that ultimately becomes an option for our patients with atrophic AMD. And there are at least 3 other studies ongoing in Australia at various stages, looking into different treatments, and they're all at the moment being injected, intravitreally injected, but there are other treatments around that will be oral rather than being intravitreal. When are we going to have some sort of medication to stop the progression of the disease or to cure it? I really wish I knew the answer to that. I really wish I was the person who came up with that idea too. I don't think that either of those is going to happen in the near future, but obviously there's a lot of work being done on that. Is MPOD, so macular pigment optical density, useful in diagnosing or monitoring AMD nowadays, or should we just use OCT and imaging with fundus autofluorescence? I think the short answer there is that, I mean, MPOD is used more in a trial setting, and essentially what it's doing is measuring the density of carotenoid pigments in the macula, and it's certainly not something for diagnosing AMD. So AMD diagnosis is clinical examination, and obviously use fundus photographs to document those findings, and then OCT plus minus autofluorescence. You can use OCT for monitoring atrophy, but autofluorescence is what's usually considered as the standard. And between those three modalities, that's more than enough to accurately diagnose and classify it, and then to monitor progression and things like intermediate AMD progressing into neovascular AMD, or if patients have atrophy, the progression of the atrophy. And you always have to bear in mind that patients with the atrophic form of AMD, so with GA, can still get CNV, and also patients with CNV will very often get geographic atrophy, atrophy around the neovascular lesion, which is different to just the isolated patches that you see in geographic atrophy or macular atrophy. So I will stop talking, and I will hand back to Sabine.
Thanks, Alex. That was fantastic. That was a really great review of everything AREDS related, and I'm sure we have a few questions that are still going to come through. I would just like to ask everyone to pop your questions into the question and answer box now, and we're going to give Alex a little break to have a glass of water while I just talk about the Macular Disease Foundation and, of course, why we're here and our part in today's contribution, or our contribution to today. So the Macular Disease Foundation, you'll all know, of course, has been around since 2001, and our main goal is to reduce the incidence and impact of macular disease. And no doubt, if you've been to any of our talks, you know that we have the 4 main pillars of work, which are very much centered around prevention and early detection, which is our awareness work, as well as supports and services, the advocacy that we do to policymakers on behalf of our community, and of course research, our research grants program, and of course data. But today I really wanted to focus on one of these pillars, which is supports and services. And I was trying to think of an analogy when I was doing a student talk a few years ago about what it's like for patients when they're diagnosed with AMD. And as clinicians, I think sometimes we get so used to talking about AMD and the eye and the macula, and patients, it's like for them as if they've gone on holiday to a foreign country before the internet existed. They don't know where they're going, they don't know the language, they're a little scared, and they may have a lot of baggage. They may have other diseases, they may have financial constraints, they may have language issues. So it's quite difficult and complex. And so as a clinician, you have a limited amount of time to impart the kind of facts that you want them to take away and advice. And so that's where referring to the Macular Disease Foundation is really important, because we can then support your patients with you and offer them the types of information that might be useful. And sometimes that's just those questions that arise when they've left the consulting room. So we offer the individualized support. So if somebody's referred very early on, we'll be talking about risk factor management. smoking cessation, the types of things that they can do at that stage. And of course, as the things progress, we can change that conversation. All of the information is offered at the right time. And everything that we provide has a very strong evidence base, which is exactly the role that Alex plays with our medical committee, making sure that everything is peer reviewed and evidence-based and not just something that we looked up on the internet. Of course, the nutrition and lifestyle is really an important factor, but what we've really had a lot of feedback on in the last few years is the importance of the mental health aspects of vision loss and the potential of vision loss. And in response to that, the Macular Disease Foundation has developed several types of peer-to-peer support. Some are face-to-face. We have 2 of those groups in Victoria. We have telephone peer support as well as digital peer support. And that's really an opportunity for patients who've been diagnosed to share their lived experience with others. And it's really powerful to see how effective that is. And of course, we help patients to navigate those government systems like My Aged Care and the NDIS, which are pretty complex at the best of times, and particularly when you might have multiple comorbidities and other issues going on in life. So that's how we support the patients. And you can refer at any time. And you'll know, of course, that all of our supports are at no cost. So how do you refer? If you use Ocular in your practice, then it's pretty easy. Every time you write a report to a GP or a referral, you can click on the MDFA referral with the patient's permission. If you don't have Ocular in your practice, then of course you can just refer directly through our website. So that's how we support patients. And of course, by supporting patients, we're supporting you in practice. But we also have conversations around the patients to support your practice as well. So a lot of the conversations are around the importance of continuity of care, the importance of attending those review appointments that you may have booked in with them, the importance of having the imaging and how that impacts early detection and progression, and also ensuring that they bring their at-risk family members to see you as well. So there's a degree of practice building in us improving the patient outcomes. In addition to that, of course, we have CPD events like this webinar tonight. We also have our quarterly e-bulletin, Macular Matters. You can actually scan the QR code because we're a bit over those at the moment. And if you're not already subscribing, subscribe to that now. So Macular Matters is a quarterly update of what's going on in the macular sector and an opportunity for you just to keep on top of what the MDFA is also doing. In addition to that, of course, this year we have released 2 education modules, online, self-paced, 1.5 hours of learning each. These were developed in conjunction with our medical committee, as well as a consortium of members, including RANSCO and Optometry Australia, and are easily accessible through all of your CPD providers, including the Luxottica and Specsavers platforms. And so that brings us to any additional questions that we may. I might just stop screen sharing for this bit and bring Alex back. We have a few questions. Here we go. All right, we're coming in hard and fast. So the first question I guess we need to address is somebody has asked what brands of AREDS 2 supplements other than Blackmore's are there in the pharmacy? And I think you were saying before, Alex, it's probably not your area of expertise. Is that impolite to say it like that? I can jump in with that one though.
Yeah, please do. What I was gonna say is that that's also my understanding. I haven't been down to be bewildered at Mr. Vitamins, but I do tell patients that there's a few that are available online, yes, and that the Blackmore's one is available in pharmacies, but I'm sure you have more info.
No, absolutely. Well, much the same. You're actually right on top of it. So there are other products. One's called MDIs and the other's called Macutech, which is available via website or by phone. There's also one from B&L called Preservision, but again, that's only online. So currently, as far as I understand, it's just the Blackmore's MacuVision Plus that fits the formula.
The other thing, sorry to interrupt. So that was to my point about what people need to take, is that the MacuVision Plus, just because of regulatory reasons, it says to take one or as directed, and so people need to take 2 of those a day to get the actual AREDS formula. So, and the other thing is, you know, patients are, as you would expect, always looking to get them cheaper. So if you buy the MacuVision Plus, then it's cheaper per tablet, but it's actually usually, unless they're on a really good special, it's usually more expensive per day. So I just leave it to patients to make their own decision.
Yeah. Is classifying Drusen as hard or soft useful? That's our next question.
Look, that as I mentioned during the talk, that's less. That's sort of fallen out of favour a little bit. It's just simpler to, you know, you could see from the both the AREDS and the Beckman classifications that it was about size. The other things, when you're assessing photographs and assessing the patients clinically, I mean, they used to talk about soft indistinct Drusen as opposed to hard Drusen, and varying sizes. I think it just simplifies things to just talk about size and not try to use hard and soft.
Mm-hmm. Have there been any interesting connections between the new COVID vaccines and AMD and AMD treatments?
Great question. So there have been associations between either COVID or COVID vaccines and just about everything imaginable. There was actually a very good editorial a couple of weeks ago in JAMA Ophthalmology by Lee Jampol, who's a very well-respected retinal specialist, and he was essentially saying that, you know, this is typically what happens at this stage. I mean, you've got vaccines that are being given to tens of millions of people, and there is going to be an incidence of, you know, all manner of things that would be occurring in the background anyway. So when there's a sort of suspicious temporal association, then people will say, oh, well, you know, that was caused by the vaccine or so forth. So the long and the short of it is that certainly, as far as AMD itself is concerned, obviously that's a chronic degenerative age-related process. So it's not really plausible for COVID vaccines to have any effect other than perhaps something like some sort of immune activation affecting AMD. But in terms of something short-term, I can't really think of anything immediately there. As far as AMD treatments are concerned, patients often ask me about, you know, is it okay for me to have my COVID vaccination the day after I have an injection or that sort of thing? And I just say, as with all these other things, I'm not aware of any reason not to. And essentially, it's more important for elderly people with comorbidities to get vaccinated against COVID than it is to you know, sit around wondering about it. And similarly, it's more important for them to have their anti-VEGF treatment.
Yeah. And just one last question. What are your thoughts on the port device?
Yeah, so the port device, for people who don't know, or the PDS, port delivery system, is a very small device. It's implanted through the sclera underneath the conjunctiva, and then the conjunctiva and tenons are sewn back over the top of it. It's tiny. It's about the size of a grain of rice, and it's not. It doesn't need to be sutured in place, and it's got a membrane over it so that initially when it's put in, it's filled with a highly concentrated version of ranibizumab. It's actually different to Lucentis, but you know, basically the same monoclonal antibody, and it has a slow release system, and it can last. Well, I mean, so over 95% of patients didn't need an injection for the first 6 months after implantation, and then if patients do need re-injection, they can have a very fine needle put through the conjunctiva and through the membrane, and it's what's called a refill exchange procedure. So the new drug is injected in, and whatever is left in there is taken out. So they're basically filled back up to what it was like when the implant was first put in. So it's very promising. It obviously involves a surgical procedure. It doesn't mean that people can sort of be, you know, sent off into the wilderness and set and forget. There are some complications that are specific to the device. So vitreous hemorrhage was an issue initially, but not really now because of changes to technique. But the main one is the potential for erosion over the implant, which at worst could lead to an infection. So the long and the short of it is very promising. Will be a good answer for some people who have more frequent injection requirements.
Mm-hmm. Well, I think that brings us to the end of tonight's session. I'm cognizant that we've run a little bit over time. I'd just like to thank you so much for tonight's excellent presentation, Alex. MDFA really appreciate the immense amount of time and effort you put into all of your roles at the organisation, and I was a bit cheeky getting you to present as well tonight, so thank you. I'd like to thank all of you for attending, and look forward to seeing more of your patients coming through for some support from us. And finally, you will be sent an evaluation survey via email from us. We would really appreciate it if you could send us a bit of feedback so that we can ensure our next session is equally better, if not better. So thank you very much and good night.